Good.
Definition. Antenatal care is the care that a woman gets from healthcare professionals during her pregnancy, having planned examination and observation for the woman from conception till birth. Components of good antenatal care are screening for pregnancy problems, assessment and categorize the pregnancy high risk or low risk, treatment of the problems that may arise during the antenatal period, and giving medications which may improve the pregnancy outcome. Provision of information regarding contraception, family planning to the pregnant woman and her family, and physical and psychological preparation for childbirth and parenthood. Principles of antenatal care. The basic principles of antenatal care are those of risk assessment and population screening. Antenatal risk assessment aims to identify the level and frequency of the care which women need due to medical, obstetric, and the social risk factors. Risk assessment should occur initially at the booking visit and is repeated in the third trimesters to ensure that woman is receiving appropriate care and to identify any need for changes in her care when the risks have been identified. Maternal screening. First comes the maternal screening. At booking appointment for the woman, should be offered screening test for anemia, hematological conditions by electrophoresis for sickle cell disease and thalassemia, blood grouping, recent status testing, and red cell antibody screen. Screening for anemia and red cell antibody screen should be repeated at 28 weeks. Once identified by screening, it is recommended for Rh negative non-sensitized women to get antenatal antigen prophylaxis at 28 weeks. Women with clinically significant atypical red cell alloantibodies should be referred to the specialist center for further investigation and advice on subsequent antenatal management. Screening for maternal infection enables the potential intervention and reduce the risk to both mother and the baby. These include serological screening for hepatitis B, HIV, syphilis, rubella. Mother to child transmission of Hep B is approximately 95% preventable through administration of vaccine and immunoglobulins to the baby at the time of the birth. Women should be offered screening for asymptomatic bacteriuria via midstream urine culture at the booking appointment. Asymptomatic bacteriuria is associated with preterm birth and pyelonephritis. However, antibiotic treatment can help and reduce the risk of pyelonephritis. Screening for GDM should be done in the women with risk factors like BMI greater than 30 kg per meter square, previous macrosomic baby weighing 4.5 kg or above, previous GDM, family history of diabetes, like first degree relatives with diabetes, family origin with high prevalence of diabetes. Women having any one of the above risk factors should be offered testing for diabetes using 2 hours 75-gram oral glucose tolerance test at 24 to 26 weeks gestation or earlier at 16 to 18 weeks gestation if there is previous history of GDM. Screening for preeclampsia. NICE currently recommends that women considered to be at higher risk of preeclampsia should have low dose aspirin of 75 mg treatment initiated early in their pregnancy and to be continued till delivery. The high risk cases include hypertensive disease during a previous pregnancy, chronic kidney disease, autoimmune diseases like SLE and APLS, type 1 and type 2 diabetes, chronic hypertension. Furthermore, the women with 2 or more moderate risk for preeclampsia are also recommended to commence aspirin early in their pregnancy. Moderate risk factors include primiparity, maternal age greater than 40 years, pregnancy interval of more than 10 years, BMI greater than 35 kg per meter square at booking visit, family history of preeclampsia, multi-fetal pregnancy. All the women should be screened at every visit for by measurement of blood pressure, urine analysis for protein. Fetal screening. The purpose of fetal screening for fetal anomalies and identifying fetal anomalies to enable the woman to make their reproductive choices, which may include termination of pregnancy. Assist parents to prepare for any treatment, disability, palliative care, termination. Facilitate birth in a specialist center if required, and allow intrauterine therapy if available.
चलो आगे चलते
अच्छा जी sir. This is a diagrammatic representation for the screening tests which are to be carried out in the woman throughout her pregnancy at different gestational ages. Schedule for appointments. Women in their first pregnancy with no complications should receive 10 appointments, and those in the subsequent pregnancies require 7 appointments. According to the latest RCOG recommendation, in total, minimum 6 face-to-face visits should be scheduled for low-risk pregnancy.
हैं चलो आगे चलते
First contact with his healthcare professional. It is usually after confirmation of pregnancy through UPT, beta HCG, or ultrasound scan. Here, the woman should receive information regarding lifestyle, advice, food hygiene, folic acid intake, information on risks, benefits of antenatal screening tests. Booking visits and the first trimester investigations. Booking appointment should be ideally between the 10 to 12 weeks. Main names are gestational age assessment with ultrasound scan offered between 11 weeks and 13 plus 6 weeks to determine the gestational age, detect multiple pregnancies, and offer knuckle translucency measurement. Assessment of maternal and obstetric risk factors to identify the women who need additional care. Discussion of antenatal screening, maternal and fetal, measure blood pressure, urine proteins, bacteriuria, height, weight, and BMI. Information on pregnancy care pathway and options for place of birth and modes of delivery. Summary of booking investigations are full blood count, midstream urine, blood grouping, antibody, hemoglobinopathy screening, infection screening, dating scan, and first trimester screening. Second trimester. Visit at 16-week gestation should include review and discuss and record the results of the screening test. Investigate if HB if below 11 grams per 100 ml and consider iron supplements. Anomaly scan should be carried out between 18 weeks and 20 plus 6 weeks, and if detect any anomaly, potential referral to the fetal medicine is considered. If the placenta is low-lying, an additional scan is repeated at 32 weeks. In case of primary gravida, an additional appointment at 24 to 25 weeks is also recommended. For measuring blood pressure, urine for proteinuria, also measures symphysio fundal height. It is measured in centimeters. Okay. Third trimester appointments. First of all comes appointment at 28 weeks. It should be for all the pregnant women measuring blood pressure, urine, investigate her HB if below 10.5 gram per 100 ml, and offer anti-G prophylaxis for Rh negative women, measure symphysio fundal height. At 31 weeks is recommended for primary gravida for the purpose of blood pressure, urine, and symphysio fundal height. And the first growth scan is offered between 28 to 32 weeks. 34 weeks should be for all. Routine antenatal care. In addition, provide her with info on preparation of labor and birth. At 36 weeks should be for all. Routine care plus check presentation of the baby. Refer if suspected breach. And second growth scan is offered between 36 to 40 weeks. At 38 weeks, it should be also for all routine measurements. In addition to info on options for management of prolonged pregnancy. At 40 weeks, only primary gravida for offering membrane sweetening. And at 41 weeks, for routine care and date of induction of labor. It is the schedule of antenatal visits designed by WHO. It consists of total 8 contacts. First contact should be up to 12 weeks. Second and third contact should be at 20th and 26th weeks in second trimester. The rest of the contacts are of the third trimester, like on 30th, 34th, 36th, 38th, and 40th weeks. So, according to WHO, women should, as soon as you're pregnant, seek antenatal care for relevant and timely pregnancy information, emotional support, and advice, and medical care. Thank you.
Nice. अब मैं स्क्रीन शेयर करूंगा. But, uh, most of you have heard what Dr. Fiza. She actually summarized the antenatal care, how it should be done, and she referred to nice guidelines. Also, maybe mentioned RCD, but emphasis was on WHO criteria. And the first question is generally we are used to another schedule in hospitals in which in the up to 28 weeks there is antenatal schedule is after every 4 weeks, and then every 2 weeks, and 36 weeks onwards there is a weekly antenatal care schedule. WHO's which comprises of uh, 8 visits totally. It also takes into account resource poor areas, for example, in Africa or in many parts, even in Pakistan, where there are no doctors and no proper maternal health facilities. Even 8 visits would be enough instead of the usual 4 weeks, 2 weeks, and 1 week schedule. So those visits have to be seen in that context. If we look at this discussion of antenatal, what do we want to understand from this? These, in my point of view, are the learning objectives, that we know what are the principles of routine antenatal care, and what is the rationale for that purpose and clinical investigations, etc. during each trimester. Why do we do those? And again, important is to differentiate the normal pregnancy from potential underlying pathophysiology or which may be there, so that we have a good understanding of the situation. Aims of antenatal care would be, as a matter of fact, if you look at the objective of obstetrics, what is obstetrics? Obstetrics broadly means, number one, that every pregnancy should be wanted. Number two, the woman and the fetal well-being should be looked after in such a fashion during pregnancy that after the birth, the woman is in a better state and the pregnancy results in the birth of a live, normal baby. So that the woman's health actually during the pregnancy improves and the pregnancy results in a normal, healthy, live baby. So that is obstetrics. And whatever we talk about, whatever we discuss is focused towards that. So therefore, assessment of risk factors so that we take appropriate measures to ensure the health of the mother. At the same time, we assess, of course, to have a live and healthy baby, we have to look at the growth of the baby fetus and then educate the patient. We use the word patient for want of a better word. Instead of every time saying pregnant woman, we say that it is patient. Although pregnancy is a physiological process and a woman who is pregnant is not sick or ill, and therefore is patient terminology is exactly not appropriate for that. And if there are any complications which will affect the outcome of the pregnancy, those should be handled. And of course, reduction of maternal and perinatal mortality and morbidity. This is important. You see, you need to know what is the current perinatal mortality in Pakistan. That is a very good index of the kind of health services which are available to a community. If the perinatal mortality and health is compromised, if there is high perinatal mortality, that means overall health standard and health facilities are rather poor. And this is an index of overall health. And so for maternal health, we'll come to some of those figures in later presentation. So optimize pregnancy outcomes for women and babies, prevent, emphasis on prevention also. Detect, for example, prevent anemia. Detect and manage those factors that adversely affect the health of a mother. Detect and manage, for example, preeclampsia. to provide advice, reassurance, education, and support for the woman and her family to right from the beginning start telling about diet, about sleep, about exercise, so on and so forth. And it is not only for the woman, but also for the family to provide her support in the family and to deal with minor ailments of pregnancy. She has acidity, she has aches and pains, backache, so on and so forth. And similarly, to provide general health screening. And when you screen for so many things, then there is general health screening also. And for example, we carry out a glucose tolerance test around 24, 28 weeks. That affects not only pregnancy, but also the ultimate general health. So you could advise about the weight, about that. And if you, when you have screened for diabetes or gestational diabetes, that would be a marker of development of diabetes later in life. And if at this point in time, if the pregnant woman is advised and counseled about maintaining a healthy lifestyle, maintaining healthy weight and diet and exercise, then her development of her diabetes, type 2 diabetes, may be postponed for a number of years. So if it were to develop at 40 years, it may develop at 60 years. So from this point onwards, we know that this is there is a greater possibility or likelihood of development of type 2 diabetes in this woman. So you can advise them accordingly. Maternal mortality. This presentation was prepared about a couple of years back, and Pakistan maternal mortality figures they keep on varying. For example, 4 years back they were a little lower, and now they are again high. These days, figures they are around 178, 100,000 live births. Now compare that with a developed country like UK. In UK, it is 9. In Pakistan, it is 186. In Sri Lanka, it is less than 30. Sri Lanka is also a developing country, and within this region of South Asia, and maternal mortality is 30. What are the factors for that? After all, this is something, and in some of the African countries, it is still pretty high. And from this, you also need to spend a little bit of time to look at SDGs, Sustainable Development Goals, and what are the in that SDG 3 relates to health, and particularly 3.1 and 3.3 and so on. They relate to women's health, and one of the objectives is to reduce maternal mortality to less than 70 per 100,000 for every country. Now, looking at the developed and an underdeveloped country, you can see the difference. And we all know that regular antenatal care that helps in reduction of maternal mortality. Now, the booking visit, these days, what we call, instead of that booking visit, it also provides you an opportunity for pregnancy dating. The emphasis with advancement in ultrasound and with the calculation of the size of the embryo and then the fetus. Embryo is still 8 weeks, and after that it is the fetus. So if you have a woman with 8 weeks pregnancy or 7 weeks and 5 days pregnancy, and with the crown rump length, you find that the duration of gestation is 7.7 weeks and 5 days. That helps you calculate the more or less exact pregnancy, and its accuracy is much better than what we used to calculate or what we still calculate with the dates. And therefore, and in early weeks of pregnancy, the dating is more reliable. So early on in pregnancy, it is not that at 10 weeks, the woman should report as early as she finds out that she is pregnant. Now, why is generally said that you have just one examination in the first trimester? It is overburdened the health system with too many visits. Therefore, that's why it is considered that, as Riza said, that the first visit may be at 12 weeks. So that is not all. But if it is possible and if facilities are available, it should be as early as possible. So you know that there is pregnancy, you can see intrauterine gestation sac or development of a yolk sac and then the fetal poles and so on and so forth. And at that time, you go through, this is, these 5 points are general management of any problem in medicine or any medical field, which is history, examination, investigation, identification and treatment of complications in general advice. These are the 5 components which relate to management of a patient in any specialty. And so they would be applicable in obstetrics and also in pregnancy. Now, we developed a chart here, and we had it in services hospital. It is of 4 pages. It's a card, antenatal card, and I think that it still provides enough information about the and record also. If you go along with that, in this whole page, the first page relates to the history. So starting with, I will try to go through identification details. You see, each of these name, age, education, duration of marriage, planning, pregnancy, these are important. Age, for age, someone is 35 years of age or 38 years of age, there are issues with that. Someone is 16 years age, too early. So that is important. Education, that also tells you whether the pregnant woman will be able, how do you communicate with that? And what time will you take to make her and the family understand things? Duration of marriage, planning pregnancy, was there a period of infertility before that, etc. And similarly, pregnancy history, LMB, you calculate the gestational age from that. And gynecological history, that's also important because if there was irregular menstrual history, that would affect the calculation of the menstrual, the gestational age. And obstetrical history, we'll come to that detailed obstetrical history as is given in the lower half of this card. I'll show you the detail of that later. Family, diabetes, hypertension, twins, hereditary blood disorders, and abnormal babies. You can just go through, and of course, you can add a few other relevant things if there are medical, diabetes, cardiac hypertension, blood transfusions, allergies, etc. Personal, social, allergy is given here in personal, social, economic history. And this is the detail of the obstetrical history. I would emphasize that in all our patients, and some of them, they have multiple pregnancies, and when you are taking his examination, it may sometimes take a longer, but you have to practice that. If you have a gravida 9 woman who has had 4 abortions and 1 stillbirth and 2 cesarean sections, 2 normal deliveries, so on, it might take a little longer. But if you use a certain approach to getting that history, then it should not take a lot of time. Remember, you have to complete your history in a short period of time, but practice about that, and you have to establish a rapport with the patient when you're asking, so that you guide the patient in telling you that history. But anyway, this is the detail, which is numbering of pregnancies, date when she delivered, actually, then when she delivered or when the pregnancy finished. Duration of pregnancy, how many weeks, full term or etc. and so on. And then ये तो उसका है मेरा ख्याल है इसी के जो देख लो ये हो जाए. And complications on the previous pregnancies, labor and puerperium. These 3, delivery, D stands for domiciliary, means at home or in the hospital. Baby alive, stillborn, gender of the baby, weight of the baby, and present status, alive and well. And if you look at the top, that is parity, stillbirths, neonatal deaths, preterm, abortions, ectopic, alive, male, female, multiple gestations, malformation. So this gives a reasonably comprehensive idea of her obstetrical history, and this is how it should be dealt with in antenatal cases. Establishing gestational age, there are various methods. Niggly's rule is the one that we generally use when we add 7 days and count 9 months forward or 3 months backward to give you the month in which the delivery would be expected. So 280 days, it has been calculated by many. there were many surveys. In one, it came to be 282. In one, it was 278. And they decided for that mean of that 280 days or 40 weeks from LMB, which would make it, if in a cycle of 28 days, 266 days after conception. But ultrasound accuracy in first trimester is of 7 days plus minus maximum. Whereas if there hasn't been any, there is a problem in third trimester, it can vary up to 2 to 3 weeks. And that because normally if there is a baby who would weigh 5 pounds, it may be absolutely normal structurally and all that. And a baby who would weigh 8 pounds, there would be discrepancy obviously in the parameters that you biometry of the fetus. That's why there is that kind of discrepancy in later days of the pregnancy when you look at the ultrasound estimation of gestational age. And here, if you look at in the antenatal record, which generally is not available in labor room for you, but when you, if you see in my records in my clinic, we go along the EDD calculated by the first trimester scan. In later scans, it may be higher or maybe lower or earlier or later, but we go according to that. And nothing else is available. Then you generally ask a woman, depending on her duration of pregnancy, when she started feeling fetal movements. And saying that fetal movements were felt in the 5th month is not correct. You shouldn't be, as postgraduates, you shouldn't be saying that quickening started in or fetal movements were felt in 5th month. When was the 5th month? Actually, what you would say, and if she would say that she felt quickening you should relate it with some landmark in the calendar. For example, KG, wo choti Eid se choti Eid ke around hua tha. So then you would know choti Eid was on 22nd of April. So at that time she was 20 weeks, and then you can calculate. Or Ramzan se pehle hua tha, baad mein hua tha. So aise. So wo cheez hai, because with that then you correlate. Don't say that it was felt in 5th month. That of course is, but when was 5th month? Because from that you would be calculating the duration of pregnancy. General physical examination, again, I've emphasized it so many times that you develop a methodology of completing the general physical examination. This is the second page of that card, which starts from above. So general physical examination, I must have narrated to you that we had a professor of medicine who would carry out general physical examinations in 2 minutes. And he would at that time take the blood pressure of the patient himself. That was included in those 10 minutes. So starting from head to toe, he would examine and he would go through that. So it doesn't take long, but you have to develop that methodology, that routine, and you practice that, you master that, and you go through that. Similarly, CVS respiratory system, you just have to put stethoscope at 4 places on the back of the chest and listen to the front of the chest for the heart sounds, and have some impression. I am very poor at that. I'll admit that, and I have put up and I've gone through all my career with that. But I would want you to do that, incorporate in your system to do that. Then abdominal examination, generally it is said that obstetricians feel of the palpation is should be the best. The reason, because our job in pregnant women is to palpate the abdomen, find out where the head is, on which side of the abdomen is the back of the fetus, on which side, and what is the estimated amount of lighter, what is the body height, etc. It has to be gentle. It has to be very softly carried out, because if you do it vigorously, the patient's muscles would become tense and the examination wouldn't reveal a lot of information. So you have to be very gentle with both hands, and you have to develop that methodology. You go through Leopold's maneuvers and all those. So that this again is something which is, I'll tell you my routine, even now, although it takes 10 seconds for an ultrasound probe to be placed over the patient's abdomen, and you would see what is the presentation, what's the amount of lighter, which side of the back is, and where is the fetal cardiac activity, and where is the placenta. These 4 or 5 informations you identify in just 10 seconds. So what is the point then? One can argue of palpating and doing all that. But that is developing your own sense of where the baby is, your own sense of how the baby's, where the baby's head is, what is its position vis-a-vis the pelvic brim, and what is its likelihood of going down, and how do you tell the patient what are the possibilities, or if there are any issues with the possibility of normal or normal delivery or not. If the head is projecting too much forwards over the pubic symphysis, and that I'm talking about in the later weeks of pregnancy. So therefore, it is important. You cannot say that there is no room nowadays if with ultrasound for abdominal palpation. There is, and you must develop those skills. You must develop that sense of assessment of the fetal parts and the abdominal palpation, and also listening to the fetal heart. Now, whether you listen it with a stethoscope or with the microscope, that is up to you. But traditionally, still, I think that Pinard's. But you people don't listen to that with Pinard's. You don't. You do it with the Sonicate. Now, Sonicate is there, so you don't even need Pinard's. But where do you put that Sonicate? You just go around and looking for that. But if you had palpated and you knew where the back of the baby is and where the fetal heart would be heard with the maximum, yes, at the back of the fetus, and since 95% are cephalic presentations, then therefore it will be a little below umbilicus on left or right, and mostly the back of the fetus is on left side of mother, mostly, and some on the right side. Now, from that, you can also have some assessment whether she is going to be occipito-posterior presentation. Because if you can't hear, if you hear the fetal heart with maximum intensity on the a little below and left of umbilicus, and also almost close to the renal angle on right side, then that is going to be right occipito-posterior position most likely. And then you should be looking at the head, palpating the head from that point of view. How does the head feel at the brim? Where is the occiput and where is the sensiput? So this all adds up again to what I said earlier, that you have to develop that feel. You have to train your hands in feeling and identifying the various parts of the baby on abdominal palpation. So going through there or just naming these various points is not enough. It is important that you develop those skills by which you can, by just gentle palpation, you can have a good assessment of the fetal size, fetal position, and the level of the head in relation to the pelvis. Investigations. These are a set of investigations, and in addition, you may request investigations which would be required from time to time or depending upon the woman's issues. Fiza talked about screenings and those tests which are carried out like NT and all those. No, that's totally one of another subject, which is screening for various problems like screening for preeclampsia, screening for chromosomal abnormalities. Those have come, and we'll take that up in one of the presentations again. Now, urine generally should be repeated at every visit for particularly protein, but at the same time, we do not pay a lot of attention to urine examination. But if you would look at that, it provides you a lot of information. If you just look at specific gravity of urine, you look at casts, you look at the number of pus cells, and for that, if there are a lot many pus cells, then you must tell the patient to take proper midstream specimen of urine. And please, if you are not sure about that, look up in the book how to collect a proper midstream specimen, and you must instruct the woman in that fashion so that she collects a midstream specimen. CBC, blood sugar random and postprandial, but glucose tolerance test, these are carried out from time to time, and we'll come to that. Blood group, RH factor, and many a times when we in the examination, I would ask a candidate about what the investigation would be. She would start with blood group and RH factor. Whereas I would start with urine CBC and I would go along that. Rubella antibodies, of course, IgG, hepatitis B, surfactant. Now we also, in addition to these hepatitis profile, we also look at HIV. Then there is a different system of assessing the risks which may be there. And in the card that we designed, I will show you that we have made a list of that. Now, this is medical history risk factors, abnormal pap test, chronic hypertension, etc. So, and according to that, you give the points to that and see. Pregnancy risk factors, these are various scoring systems which were used, and current pregnancy risk factors. So in the medical history, in the other obstetrical history, in the current pregnancy, so these would be the risks at which you will finally add up to a risk score. Now, this is the one that we developed in our card, which is pre-pregnancy, age, weight, height, diabetes controlled by diet only. Now, that would be A1, A2, GDM, etc. Or then or insulin, retinopathy, heart disease, hypertension. This is pre-pregnancy. Past obstetrical history, neonatal death, stillbirth, abortion, delivery at 20 to 37 weeks, which cesarean, small for days, large for days, RH isomerization, major congenital anomalies, Down syndrome, etc. And current pregnancy, diagnosis of large for dates, etc. And polyhydramnios, and then at risk factors, other major fetal anomaly and acute. So you add up that risk score, and here medium risk score would be 2 to 6. And if the score is total more than 7, then it's a high risk pregnancy. So you write down on top of the card that it's a high risk pregnancy, and therefore you manage that, or you encircle that, and you will take care of the patient according to that. Okay. Right. So in the first trimester, it is important. When I was viewing these slides, I suddenly realized that I don't spend not that much time with my patients. I don't tell them all that. There was a time when I would spend about 20 minutes with the patient, and I would chat with her and tell her all about those things. Nowadays, also, if I get a little bit of time, I do that. But I would emphasize इस स्कोरिंग का जो मैंने अभी चार्ट ये वाला दिखाया है, इसका नाम तो कोई नहीं है, लेकिन देयर आर डिफरेंट. ये जैसे यहाँ पे था मॉडिफाइड हॉबल स्कोर. हॉबल did it in probably 70s. तो ये फर्दर हो गया 1984 में ये हुआ था. उसके बाद इंडियंस में जैसे है, उन्होंने एक दास और एक दुरू है, उन्होंने अपने स्कोर बनाया हुआ. इसी तरह से आप कर सकते हैं. So ये है रिस्क स्कोर्स हैं. Anyway, now we come to this. So you tell the woman about physiological changes. Every system of the body actually gets affected by pregnancy in one way or the other. May it be cardiovascular system, musculoskeletal system, intestine, bowels, brain, emotions, etc. Everything. So you just tell them that these are physiological changes. You have to expect that your blood volume increases by almost 30 to 40%. And there is hemodilation, so on and so forth, and weight gain, and it will affect your sleep, but you should take some rest. What kind of diet, daily activities, exercise, relaxation, what kind of exercise can you do? Not strenuous, not vigorous, or contact sports, hygiene, teeth, bladder, bowels, sexual counseling, smoking, medication, infection. So all these, travel, follow-up, minor discomfort, signs, and potential complications. So you brief the woman about all these points. They should be in front of you, and you should be telling the woman about that. Dietary advice, I generally tell, don't eat for two, eat for only one. You just have to take yourself. And these are dietary advices that it should be rich in what, and obviously You avoid that, what do you call that? Junk food, etc. But once in a while, that is okay. I also like that. Dieting in pregnancy is not recommended, but controlling weight gain in pregnancy is advocated. Restrict intake of fried foods, drinks, etc. I do ask them not to take cold drinks, Coke, etc., not even diet ones, because they add unnecessarily and confectionery items. Or other late mujhe na bata. Now, weight gain in pregnancy. This is important for you because we need to educate our women about that. There isn't any fixed weight gain, but generally speaking, if the BMI now, even these days, even BMI is under review, that we should be sticking to BMI or we should have some other definition of obesity and go according to that. But we'll go into that later at some later point. So BMI, if it is within the normal, then 11 to 16 or 20 kilograms or 25 to 35, I will take it to only 30 pounds. Generally, you make them understand. And most of that this weight gain is during the second half of pregnancy. In the first half, at 20 weeks, what is the weight of the fetus? 400 grams. 400 grams. And placenta also is not being really that much. Up till that time, the blood volume also hasn't increased that much. You see, blood volume increases by 30%, which is instead of 4.5, it will be about 6 liters. So that would be added weight and deposition of fat, development of breasts, weight of the uterus, blood. And at any given time, there are 700 milliliters of blood flowing in the uterus. So weight of the placenta and all that. So that adds up a lot to that. But total weight gain, 25 to 30 pounds, that generally is. But then they should not be eating to gain weight. That is something that you look after when when the woman comes to you for antenatal. You look at the weight and how much she has gained. Overweight women, the weight lumps becomes less, and those who are obese, who have a BMI of more than 30 kilograms, their weight gain should be restricted to only 11 to 20 pounds, so 5 to 9 kilograms, and they should be nutritional supplement, folic acid, iron supplement, vitamin D, vitamin A should be restricted. Activity, this is important. Normal levels of activity are acceptable. Exercise is okay. Like a heart rate, it should not go beyond 140. ऐसी exercise, no. Avoidance of traumatic activities like contact sports, travel is all right. Pressure, aircraft, intercourse not contraindicated, but if there is bleeding, spotting, it should be restrained. Common symptoms, we have to attend to that. Nausea, vomiting, heartburn, constipation, backache. These are the usual complaints. Yes, I'll send that this presentation. And similarly, hemorrhoids, varicose veins, vaginal discharge, and in later weeks, candidal discharge is quite common. But you also should have a look at the discharge before you prescribe any medications. Nausea, vomiting, appetite, first trimester settled by 16 weeks. If severe, hyperemic drugs, small frequent meals, pelvic pain, ligament. They usually complain of वो जो औरतें जो नवजाती नलों में दर्द हो, नलों में दर्द ये होता है कि वो ये I invariably tell those women that do you have pain here? And that is because when the uterus rises up, there is stretch of the round ligaments. Now round ligaments are here and they are attached here, just below the pubic symphysis, right? So if you tell them it is here, then you explain to them that this is because of the stretch of the round ligaments and it gets better after 24 weeks. So that's quite reassuring. Then the woman doesn't ask for an analgesic. She would just be happy with that you have explained and it is normal. Similarly, in later weeks of pregnancy, in 37, 38 weeks, when the lower segment starts to form and it dilates and there is stretch of the peritoneum and it is tender. Mind you, at that time, even after having asked the patient to empty her bladder and then you start palpating, you should be very gentle. You shouldn't be really dipping your fingertips too hard into the patient's lower abdomen. It should be gentle because at that time, just little it would be tender on palpation. And that doesn't mean that it is going to burst open or something, but that just means that there is stretch of the peritoneum. Similarly, many women will have that discomfort of pubic symphysis. And if you just put your finger over there, they'll say that they have pain. And that's because this fixed joint of pubic symphysis, this becomes a little relaxed, and there is even a fraction of a millimeter's movement over there that is painful. And many women will have in later weeks of pregnancy, say after 32 weeks, they'll have some, they will have a tender point on the right side, hypochondrium or the rib margin usually. And that's because the uterus touches that and makes it a tender point. That's that thing. So ankle swelling, it's when they say swelling, and if it gets better in the morning. Urinary frequency at various stages. In early weeks, in 10, 12 weeks, the uterus is pressing upon the bladder, and that's why there would be pregnancy. But you have to identify that. Frequency of checkups up to 28 weeks, every 4 weeks, and if there are problems, then it may be more frequent, like in high-risk pregnancies. This is subsequent visit, and every visit you ask, how have you been since your last visit? You ask that. And if there are any problems, you ask about fetal movements, weight, blood pressure, edema. These are the general physical examination. Abdominal examination, you know all these. These are to be carried out in later weeks. So pelvic examination, generally I don't do pelvic assessment. Abdominal assessment generally is enough. Pelvic, even I don't do clinical pelvic assessment, but do look up in the book what is the role of pelvic assessment at 36 weeks in priming gravida. So that you can do, but pelvic assessment in itself is subject of a talk. Lab tests, urine dipstick for proteins. Abdominal examination, estimation of weight, kaise hota hai? You just have an idea about if it's an average height woman, then you would palpate and you would see, you would have an impression that comes only with experience. When you do that and you make a mental note of that you think that it's a baby who will weigh about 3 kilograms. Now, even after you have delivered the baby and you have held the baby in your hands, sometimes you say 3.2 kilograms and it turns out to be 3.3 or 2.8 or whatever. So you then have hit and trial, and then you learn, and then you have that feel, and then you would know what's the weight of the baby. So urine dipstick for protein every visit. If that would take into account that you have it available at the antenatal clinic, you do it yourself. Or hemoglobin at 24 weeks, glucose tolerance test at 24 weeks. Now it is standard 75 grams. There is no point of 50 grams or 100 grams. Stick to this 75 grams, fasting 1 hour and 2 hours. And prenatal screening for group B streptococcus, we don't do, but we should be doing that. Subsequent visit, 16 weeks, we review, discuss, record results, screening test, ultrasound for structural abnormalities. One ultrasound was at 11 to 13 weeks and 6 days, which is for nuchal translucency. 28 weeks hemoglobin, वो नीचे है, NTD prophylaxis. 34 weeks preparation. We also have this schedule that we have a chat with the patient around 34 weeks, telling her about the preparation for labor. 36. Warning signs, decreased fetal movements, vaginal bleeding, edema, hands, face, severe headache, blood, and right upper quadrant pain when there is stretch of the capsule of liver, dysuria, leakage of fluid, ultrasound, diagnosis of pregnancy first, earlier, then dating scan, CRL, multifetal pregnancy, early status pregnancy. This is the information that you have on that first ultrasound, and anti-scan at 11 to 13 weeks, and this is first trimester ultrasounds. Second trimester anomaly scan, the central localization at 22 weeks, cervical length were indicated, and then third trimester fetal growth at 32 to 34, biophysical profile, fetal vessels, Dopplers. Doppler in second trimester is not relevant actually, so don't go for that. These drugs are safe during pregnancy. These drugs are not safe during pregnancy. NSAIDs, especially after 20 weeks. So remember, don't give NSAIDs after 28 weeks. They cause premature closure of they cause PDA. And immunization safe: tetanus, hepatitis, influenza, meningococcal, rabies, and unsafe vaccines with live attenuated virus, mumps, measles, rubella, varicella, and ये बंद हो गए. स्लाइडें खत्म हो गई. अच्छा हाँ ये नहीं थे यहाँ पे ये ये इम्यूनाइजेशन हो गई। फिर प्रीनेटल डायग्नोस्टिक टेस्ट हैं, इसके बारे में हम कभी बाद में बात करेंगे। ये है एंटी स्कैन वाला है, उसके ऊपर आ गया। एंड ये नीचे वो दूसरा आना शुरू हो गया। सेल फ्री डीएनए टेस्टिंग आजकल आ गई। ये ट्रिपल टेस्ट और क्वाड्रुपल टेस्ट अब आजकल हम नहीं करते, लेकिन उसकी इंटरप्रिटेशन ये थी काफी डिफिकल्ट सी है, लेकिन इसको भी चार्ट बना के बंदा साथ रख ले तो ठीक है। एक मिनट। ओके So all pregnant women, regardless of age, should be given the alternative option to undergo invasive genetic testing. ये आगे ये है amniocentesis or CVS wherever there is indicated. And ये बाद में ये और subject है, इसके ऊपर नहीं हम आ रहे, ये ठीक है। So this is antenatal care. But the important thing is that I would urge all of you to involve yourself with the patient. Don't just see her as a patient. You have to kind of be compassionate. You have to be empathetic. You have to be sensitive to the patient's need. Every patient is looking for a sympathetic ear, a pregnant woman. So you have to listen to her. You don't have to just dismiss her complaints. Listen to her complaints and then one by one address to those complaints and tell her how her pregnancy is with a reassuring tone. And if she needs, if she has developed some complication, then again, it should be a kind of reassuring way, but of course, making her understand that she has those issues and she needs more visits, she needs visits, or if she hasn't controlled her diabetes very well and her blood glucose levels are not good, and you are not happy with those, again, try to explain to her how important it is for those levels to be kept within that range for her own sake and more so for her baby's sake. When you emphasize that, she will be more compliant. Right, so I'll share this presentation with the local WhatsApp group of residents, and then they can, of course, disseminate it to all of you. If there are any questions, I'll be quite happy to respond to them.
Excuse me, sir. Assalamu alaikum. सर अभी आपने ओरल ग्लूकोज टॉलरेंस टेस्ट का बताया कि हम 75 ग्राम के बाद फास्टिंग 1 आवर एंड 2 आवर देते हैं। हम तो नाइस को फॉलो नहीं करते जिसमें हम जस्ट 2 आवर की वैल्यू लेते हैं।
नहीं, उसकी वजह ये है कि 1 आवर को हम इसलिए अहमियत देते हैं बिकॉज the objective is to keep the blood 1 hour blood postprandial blood sugar below 140 milligrams. So that is the objective. So I would rather stick to 1 hour instead of, if I have to do just one reading after glucose load, then I would stick with 1 hour, not 2 hours. We ask our patients to have their blood sugar levels tested if they have to maintain a glucose postprandial glucose record. Then she needs to have 1 hour after breakfast and after lunch and dinner, 1 hour after each of those. So that is because that is the level that we are trying to achieve, which is less than 140. Yes, why we are still giving tetanus vaccination to the patient? I do not. Professor Rashid did, and we, in the last 20 years, we haven't been doing that, because you are absolutely right about that. And many patients, but you see, we are not at the same time, for those who would give it, how many of the general population, we do not have figures for that. How many of them have had tetanus toxoid immunization in their childhood? I actually do not have those figures. Please find that out. And if that is, we do not know, then it might be a good idea to provide at least one booster shot at 28 weeks. We could give that, but I don't get into that. I tell them that you had it in your childhood, you are immunized against tetanus, so you don't need it. And if you haven't had it in the last 5 years, you can have one. So that is it. I don't really get into that. But your question is valid, a little arguable though. Cell-free DNA, I don't think it is available as yet in Pakistan. No. Right. Thank you very much. Bazi, recording बंद कर दी.